When babies are born with complications, they usually wind up in neonatal or pediatric intensive care. Mothers and babies are routinely separated for weeks or even months. Babies in care can still get the benefits of their mother's breast milk. But sometimes things can go wrong.
We had two milk banks, and one functioned very fluidly and one was starting to have some real challenges and had kind of a couple episodes where wrong milk had been delivered or administered to a patient. The topic became, how do we address wrong milk delivery?
This is Jordana Goldman. She's a pediatric specialist based in Texas.
For the Heart Center, and then was working kind of also on the hospital-wide level to advance safety science within the institution.
When errors, like this mix-up with the breast milk, continually crop up in healthcare, institutions typically see this as a problem with their operational systems. Most often, they turn to health administrators and systems experts to fix it. But frequently, their recommendations simply increase the day-to-day burden on healthcare workers, while doing little to prevent these errors from happening again.
The models that we've been working with, which are just more regulations, more box checking, more confinements, really haven't made significant progress. And if anything, sometimes just impedes people's natural ability to do their work and to be able to make the adjustments that are needed to get that good outcome or what we're driving towards. And so as we're learning about this and we're seeing this event unfold, and it seems so simple, but it just keeps happening, it made us think, like, could we look at this differently? Is there more here?
Jordana wanted to take a different approach, one that harnesses the expertise of those actually doing the work. Learning teams is an improvement concept that's about bringing people together and learning from the people who are on the front line every day. It's about learning from those who know what is working well and what makes their job harder or less safe.
How much you interact with the people who are doing the frontline work and in what ways you're interacting with them can really significantly affect the output that you get from that methodology. And if you're not asking, then you may miss a really crucial point. We started with choosing who would be the facilitators for the group. We had two of our patient safety specialists who are nursing trained be the initial leaders, and then I joined on kind of as a content expert.
In a learning team, it's essential to get people who regularly do the task you're analysing. But the team has to be a mix of people with different degrees of experience. The perspective of long-term employees versus short-term employees can really be quite varied. No supervisors or leaders, they are the recipients of the learning team, not the participants.
The value of having non-content experts in the field asking the questions, because the curiosity is just more native, and because we just ask very simple questions that don't make sense to us, that make sense because you're so used to being there. Like, these assumptions that you've lived with, they don't exist with the strangers who are entering your environment. So when a stranger comes and says, well, but why are you always only turning left? And they're like, oh yeah, my right blinker's broken. You're like, oh, okay, great. Do you want to fix it? So we discovered that setting up a 3-hour meeting in a healthcare environment wasn't a thing. So what we ended up doing, knowing that we only had an hour, was we decided to just start with, tell me about your everyday. Once they started talking, they filled up that hour very quickly.
Once this process began, a lot of powerful insights started to emerge. These insights were not part of the administrator's recommendations, and in fact really ran against them, but were nonetheless grounded in the common sense of those at the coalface. The learning team developed a simple and ingenious way to lower the chance of a mother's milk going to the wrong baby. An elegant solution that went beyond the administrative status quo.
they weren't quite exactly using true two-step verification or two true patient identifiers. So one of the patient identifiers that we classically use is last name. Using that as a patient identifier is kind of an opportunity for loss in your checks and balances, because there's going to be a bunch of Goldman babies potentially, and it no longer is significant. So what they hadn't had before was somebody's full last name and then their full medical record number. There were a lot of errors, I think, because people were using the full last names and just putting it in the bins.
The solution involved taking the first 3 letters of the surname and combining it with the last digits of the MRN.
And so when they took away the full last name, so you couldn't just pick Goldman, and had to look for something else, that last 4 of the MRN, that had actually decreased their work burden and increased the likelihood that it would end up in the right bin.
This solution taps into something cultural. Looking at surnames, often the same surnames, day in, day out, creates a risk of a mix-up. So rather than full surname, full MRN, this solution involves taking less information, but combining it into something that forces us to take a second look. The learning team's solution really forces hospital staff to passively perform a 2-factor authentication every time they look at a label.
When the administrators come in and the engineers come in and they look at it, they think this is crazy because they don't think about the human factors piece of it.
It's a solution that didn't come from the experts. It came from giving a voice and listening to those carrying out the work.